And thank you all for attending this Pancreatology Symposium for Primary Care. I want to thank the charity Pancreatic Cancer Action for inviting me to speak. And what this chat is going to be about is what we are doing right, but also how we can be better. Just to summarise the journey of how I came to be interested in pancreatic cancer and early detection, about 2 years ago, I think now, Pancreatic Cancer Action approached the Royal College of GPs and we worked collaboratively to develop a 45-minute online learning course aimed at not just the GPs but at primary healthcare teams, looking at ways that we could improve the early detection of pancreatic cancer in primary care, knowing that it's such a difficult disease to diagnose early. And I've spent the last 3 years working with practices, with GPs and with CCGs across London, looking at how we can detect not only the big four cancers earlier, but also the ones of lower incidence with higher mortality rates. There are several reasons, as I'm sure we all know, why cancers are diagnosed late and what contributes to delays in diagnosis. It's complex, it's multifactorial, it can range from patients being unaware of when to be concerned about their symptoms, through to patient fears of a sinister illness, through to not wanting to waste GP time, through struggling to access their GPs promptly, delays within the primary care setting itself, accessing urgent investigations, and then subsequently delays in secondary care, getting to the final diagnosis. As I mentioned, there is a national focus on the big four cancers, but I think it's important, being Pancreatic Cancer Awareness Month, that we do spend some time thinking about pancreatic cancers. Several organisations feel very passionate about this. I mentioned Ali's organisation, but also the Royal College, CRUK and Macmillan. It's important that we reappraise our knowledge and also talk to our patients about when they need to be concerned. The interesting thing about pancreatic cancer is a lot of it is actually presents in an emergency setting in A&E, and there's a study currently going on across London looking at all cancers that present in A&E and where the disparity is between the GP story and the patient story. So it's important that we reflect and see how we can have an influence in early detection of the big four, but also of the rarer cancers. This journey is actually also personal. My aunt died of pancreatic cancer a few years ago, and that's when it struck me how little we probably know about it, because we don't see it as often as we see the others. Statistics show that every GP in the UK, every practice, will come across one new cancer case of pancreatic cancer at least every year, and that every individual GP will come across a new cancer case every 4 to 5 years. So before we go into the knowledge, I just wanted to reassure you I'm not here to GP bash, I am a GP. And there's been so much negative media attention about the role of GPs in early detection. And as I've said, the patient journey, it's so complex and can be influenced at any stage. What we do, our job is not easy. Early detection is not easy. And my aim here is to identify where we can do better, both as a primary care force and as individual clinicians. This is just a very trimmed list of all the things that we do in a 10 to 12, and if our practice is very generous, a 15-minute consultation. And I've highlighted the ones that are most relevant in terms of early detection of cancer. And I was just thinking about how to phrase nicely what we do. We interpret the story, we explore the patient journey, we draw out discerning facts, we assess the physical, the emotional, and we triage what is self-limiting, what is minor, what is acute, what is emergent, what is life-threatening, and how do we act on the findings. How do we diagnose, when do we investigate, and when do we refer appropriately. Our roles also include reassuring patients, the worried well, for example, but also to improve the health literacy of our patients, to safety net and to follow up, all whilst being human with each other. So I thought I'd start off with a quiz. Feel free to write your answers down or shout them out to me, I don't mind. So regarding pancreatic cancer, does anybody know what the 5-year survival rate is in England? Who has it a guess? Sorry? 10%? Okay, I'll remember that from when the answer comes up. We'll get the answers along the way. But just some questions to consider. What percentage of patients present as an emergency with a new diagnosis of pancreatic cancer? I think the figures will shock you. does pancreatic cancer have the highest incidence mortality ratio? True or false? Something to think about later on. Is alcohol the most significant risk factor? And true or false, the latest NICE guidance suggests GPs request more ultrasound scans of the abdomen. We're going to be addressing those quiz questions later on in the talk, but I think those 5 questions actually highlight the changes that are going to be ensuing in the next 6 months to a year. So I wanted to bust some common myths about pancreatic cancer and refresh our knowledge on risk factors, classes of symptoms, red flags, which investigations we can order within primary care, and also talk about the use of clinical decision support tools that have had a lot of coverage in the recent months to assess overall cancer risk, but also pancreatic cancer risk. The latest NICE guidance, the draft was released only a couple of weeks ago, and the actual final draft on suspected cancer guidelines will be coming out in spring 2015. And also how we can learn from each individual cancer story. So to answer question 1, what is the 5-year survival rate of pancreatic cancer in the UK? The answer is actually less than 4%. In men, the 5-year survival rate is 3.6%, and in women is 3.8%. And shockingly, the 1-year survival rate is less than 20%, 17 in men and 19 in women. It is disappointing to see survival rates of some of the rarer cancers, like pancreatic cancer, still lag behind the majority of the most common types. If we want to compare with the 5-year survival rate for breast cancer in women, which is 85%, testicular cancer in men, 97%, and even prostate cancer, 5-year survival rate in men is 82%. So there's a massive inequality in survival rates. Pancreatic cancer for men and women combined is the 10th commonest cancer and actually affects men and women equally. And it is the 5th highest cause of cancer-related deaths. Over a third of patients are under the age of 65 and almost half are over 75. And this dispels the myth that pancreatic cancer is a condition of the elderly. That's actually not the case, with over a third being under 65. In the UK, rates are similar in Caucasian and African and Caribbean patients, but lower in Asian patients. To move on to answering question 2, which is what percentage of pancreatic cancers present as an emergency, the answer is about 50%. So half of pancreatic cancers come into A&E with acute signs and symptoms such as obstructive jaundice, acute abdominal pain, and patients being very unwell. Only 11% of pancreatic cancer patients are diagnosed through the 2-week rate referral pathway in England. To answer the third question from the quiz, in terms of is pancreatic cancer, does it have the highest incidence mortality ratio, that the answer is true. Despite having a much lower incidence than the others, unfortunately it has one of the highest mortality rates compared with any other cancer. Overall, we know it has a poor prognosis because by the time someone has developed advanced disease and has severe symptoms, they attend their doctor and they're sent into A&E, and by then the disease is often widespread. Over the last 30, 40 years, survival rates have only increased a little bit, and that's because we know it's so difficult to detect. Younger cancer patients have better survival rates than older ones. And pancreatic cancer was described as the silent disease, but actually it's now considered to be the not so silent disease, because patients do develop soft, subtle, but detectable signs and symptoms at the beginning of their onset. And if we are perhaps more aware, and patients are more aware of when to be concerned and when to discuss their symptoms with a GP, perhaps these initial symptoms and signs won't be overlooked or misinterpreted. So something to think about before we get into the actual clinical spectrum of how pancreatic cancer presents. I thought as GPs we should probably reflect on how we detect cancers, because there are so many different routes and tools that we use. Of course we reappraise our knowledge, we learn from individual patient stories, our own experiences. Some clinicians talk about having a sixth sense or a sense that there's something sinister or serious going on despite blood tests being normal. We learn from significant events. The use of clinical decision support tools, which I'm going to be coming to again later. Obviously we have NICE guidelines. We have 2-week rate criteria, and there is often a disparity between latest guidance and the 2-week wait forms that we use. Obviously screening is a route, and then other routes to diagnosis, such as urgent referrals and also the private sector. So risk factors. Research indicates that there are several risk factors for pancreatic cancer. As I said before, a third of patients are under 65 and over half are over 75. More than 25% of pancreatic cancers are caused by smoking. Using smokeless tobacco also increases the risk. People with type 1 or type 2 diabetes have roughly twice the risk of developing pancreatic cancer, and chronic pancreatitis is associated rather than alcohol use. The actual data suggests that it's chronic pancreatitis that is the risk factor in its own right. Being overweight or obese is a risk factor, and 1,000 cases in the UK each year are linked to an excess in body weight. Eating of processed meats increases the risk, and also family history of pancreatic cancer, which I'm sure we all know. There was a dip in incidence in the 70s, and this was thought to be due to a national, both in men and women, reduction in smoking rates. But in the last 10 to 15 years, it is creeping up again, and this is due to rising rates of obesity. The genes that we know are involved are BRCA2 and also the hereditary non-polyposis colorectal carcinoma gene, and also chronic and recurrent infections of Helicobacter pylori is thought to also be a risk factor. So, to answer question 4 from the quiz, alcohol is not the most relevant risk factor for pancreatic cancer. I didn't want to be too didactic in this talk. I could just reel off a bunch of signs and symptoms, but I think the most powerful way to learn and to remember is to hear from patients themselves. I wanted to draw your attention to an organisation that was formerly known as Health Talk Online, and now they're called Health Talk.org. And they are an educational resource developed by a GP, Dr. Anne McPherson, who herself was diagnosed with breast cancer, whose mother died of pancreatic cancer. And she and her team developed patient interviews ranging across all sorts of diagnoses, but they have a specific cancer section. Pancreatic cancer can be difficult to diagnose because pain in the abdomen can be due to so many different things. We may initially suspect pancreatitis, peptic ulcer disease, a pulled muscle, irritable bowel syndrome, hiatus hernia, gallstones, and there's so many on the differential that traditionally pancreatic cancer doesn't feature very highly, or at least perhaps traditionally we're thinking of pancreatic cancer as a possible cause. Something else to consider is that a third of pancreatic cancers affect the body and tail of the pancreas. So the traditional medical school textbook thinking that most cancers will just show themselves as obstructive jaundice, pale stools, dark urine, is simply not the case. As a third of the cancers affect the body and tail, they don't present with those classical symptoms, so we have to be looking for other signs. Patients have noticed pain under their ribs, in their upper abdomen, and random paraneoplastic pains across their entire body. I thought we could start off by listening to Phil and Adrian's story, and these are short patient interviews that explain what happened to them before they were diagnosed.
At the beginning of 2010, and I went to see my local GP, and to all intents and purposes we were convinced it was a duodenal ulcer from the symptoms.
Did you have any other symptoms apart from the pain?
I had some stomach pains when I used to eat. I used to get a reaction about half an hour after I ate, sort of, which again everyone thought was the food going down and irritating the ulcer. And that went on for a little while before I got these severe pains, which resulted in me going to the doctor. So there probably was a time of about a couple of months where, kind of, if I'd been more aware, I could have gone to the doctor earlier.
Mm. Did you notice any change in your bowels, your stools?
No, nothing at all. I used to like a drink quite a lot, and so the only thing I found was that giving up alcohol kind of eased the symptoms, which is what I did. So I just thought it was alcohol irritating an ulcer.
Well,
Just going to play the next patient's story to listen to the range, the spectrum of symptoms.
okay. Just before last Christmas, I was feeling sort of generally unwell, and nothing really specific, very peculiar little symptoms, such as I'd gone off my yogurt every day for years, but just didn't fancy eating it anymore. If I did eat it, it made me feel sick. And then one day I had a really excruciating pain in my left shoulder, which I couldn't think of anything. It obviously wasn't in the shoulder. I could move the shoulder, prod the shoulder about. Didn't make the pain any worse, but it was a really bad pain. So after a little while of that, a few days, I went to the GP, who said that's very probably referred pain from the diaphragm, and she gave me some antacid type tablets, which did do the job, made the pain go away, but I also reported this really extraordinary bloated feeling especially after an evening meal. And she couldn't tie that in with any other symptom that might be, or problem that might be to do with the referred pain. So she tentatively suggested IBS, irritable bowel syndrome, which was a fair enough diagnosis, but not one I was particularly happy with. So she offered me a referral to my local hospital, and I always take referrals if I'm offered them, so I duly went for that appointment, and had a blood test, which obviously was testing for a lot of different things, celiac disease among them. Very comprehensive blood test. Also 20 minutes of being poked and prodded around, at the end of which the consultant said, well, you have IBS. And I still wasn't happy with that diagnosis, but it seemed to be definitive. So I went away with a recommendation to follow a low-fibre diet, which I tried to do, which was pretty difficult because they hadn't given me a definition of what a low-fibre diet was, so it's rather difficult to follow a low-fibre diet if you're not told what one is. But I did try. Meantime, I was not feeling any better and was getting really bad lower back pains. That's not massively unusual. I have a prolapsed disc, so lower back pain is something I'm quite used to. This was different to disc pain, but I wasn't overly concerned. It was quite a bad pain.
So just from those two patient stories, we can see the spectrum of symptoms that patient may present with very early on in their disease. We've heard about IBS type symptoms, bloatedness, in addition with more classical symptoms like abdominal pain. Something else to consider is the pain radiating to the back, which can be made worse by lying down. Early on, the pain may be intermittent, but it can also then become persistent as the disease develops. So something to consider is if someone keeps coming back requiring escalating analgesia, that can be a very telling sign of pancreatic cancer. Postprandial pain, whether it's epigastric or back, is also a telling sign and something that we're probably are used to hearing, but maybe perhaps not acting more on, is night pain, and pain being so severe at night or during rest that the patient has a disturbed sleep. As we all know, and as I mentioned, the common sign of pancreatic cancer is jaundice, and that's because cancers originate from the head of the pancreas, will cause an obstruction along with signs such as dark urine, pale stools and itchy skin. But well before this happens, patients may be complaining of persistent nausea, IBS symptoms, acid reflux, heartburn that is intractable to over-the-counter remedies or proton pump inhibitors, and an intermittent or persistent sickness along with changes to the bowel habit. The early signs and symptoms can include a new onset diagnosis of type 2 diabetes in a patient of normal weight or a patient that is underweight. So that should alert you to think what was the cause of their type 2 diabetes, especially if there is no family history of diabetes. Resistant dyspepsia or persistent epigastric pain, postprandial back pain, postprandial epigastric pain, pain that worsens on lying flat, pain that worsens at night and disrupts sleep, IBS-like symptoms, especially in those aged over 45. Similar to all the cancer awareness measures for ovarian cancers, we're now being asked to look for ovarian cancers more in women over 45 who have bloatedness and abdominal discomfort. Well, we should be actually looking at shifting that similar cancer awareness to pancreatic cancer in patients with those symptoms. Increase in bowel movements, offensive smelling stools, stools that are difficult to flush, pale stools, and also patients that develop with a DVT with no obvious risk factors. That could be a sign of an abdominal malignancy, such as pancreatic cancer. And then the textbook cases that we've known about for so many years, which we're trying to avoid patients getting to this stage of their disease, whether we see painless obstructive jaundice, vomiting, weight loss, loss of appetite, anorexia, and those are sort of the more typical symptoms that we see. The red flags that we should be looking out for are, it's difficult because cancer symptoms can develop in clusters, especially for pancreatic cancer. So anything that persists or escalates should make us think of whether we should be investigating further. And I think we've talked about these red flags already, but the IBS and resistant dyspepsia are probably two. If you're going to take two takeaways from today, it's looking at patients with IBS type symptoms over 45 and patients with resistant dyspepsia that probably should be investigated further. Let's move on to which investigations matter in primary care. So we've looked at the atypical presentations of pancreatic cancer, but now we should look at which investigations matter. I think we're all used to investigating abdominal pain. We know the routine bloods to request, having access to abdominal ultrasounds, abdominal x-rays, but actually there are certain tests that you can request within primary care that may help you to decide whether there is something sinister going on. Full blood counts can actually be falsely reassuring. Anemia is very rare in those with pancreatic cancer, except for patients who have ampullary tumours. I think we all know what liver function tests to look out for in terms of signs of obstructive jaundice, but a new diagnosis of type 2 diabetes with patients complaining of fatigue may alert you to thinking, is there a cancer that's caused the new diagnosis? And also the CA19-9 is actually a useful marker, provided we understand that it has somewhat of a low sensitivity ranging from 50 to 75%, and that normal levels do not exclude diagnosis, but actually an elevated level could prompt you to think that there is a sinister process or a cancer developing. Surgeons and oncologists will say that it is a good monitoring parameter and can actually show signs of a late mass. But also two other markers that you may be able to request are beta-HCG, which can be elevated in pancreatic cancer, and also CA724 also has its use as well. But I think the most important investigation really is about the radiology. Without doubt, enhanced or high-resolution CT is the gold standard, and that answers the last question of the quiz, which the latest NICE guidance does suggest that GPs request more ultrasound scans of the abdomen, to which the answer is true, but also that we should be requesting, if possible, CT scans. NICE guidelines do recommend ultrasound scans, but they can be falsely negative, especially in patients that have more centripetal weight or patients that have overlying bowel gas. It can make tumours that are less than 2 centimetres difficult to detect. I'm not sure what it's like in this part of the country in terms of access, direct access to CTs, but I think that's something that really needs to be worked on, and very rapidly. Not only do we need direct access, but we need urgent direct access. I think this service is variable across the country, and hopefully one of the aims of co-commissioning will address these inequalities to access, and we know that that is a massive barrier to early diagnosis in primary care. And with the new NICE guidance published next year, hopefully we will see some changes with our trust services. I thought this might be a good junction to reflect on what we do in our own practice. Do we even think pancreatic cancer when someone comes in with a resistant dyspepsia or resistant heartburn? How robustly do we safety net and fix follow-up for patients that are undergoing investigations? Do you normally arrange a follow-up appointment while the patient is with you, or do you ask the patient to book their own follow-up once they've had their investigations? And also, should multiple presentations be an alarm bell in itself? And the reason why I ask this is because the National Cancer Patient Experience Survey revealed the following. So what they did was they looked at all cancers across the board and delved into upper GI cancers, and also studies were done looking at specifically pancreatic cancers. And if you look at the vertical green bar, so the third from the right, that indicates the number of patients that had 1 or 2 appointments with their GP before they were referred on. So we know that out of 13,000 patients, a third saw their GP 3 or more times, and those that saw their GP more than 5 times had a 3-month delay in diagnosis. I think it's for this reason that emphasising the importance of fixing a prompt follow-up after urgent investigations have been requested, and explaining to patients the reasons for having things done urgently and what to expect in terms of the trajectories of when to come back is something that is so paramount. And actually, even last night, my last patient of the day, I had a conversation. It's a chap with, he's a patient with, a sort of recurrent dyspepsia, and we actually talked about his risk of pancreatic cancer and whether we should be arranging a prompt CT scan or referring to an upper GI 2-week wait. Something else we talked about, I introduced my patient to this, was the QCancer Algorithm, and I just wanted to ask if anybody has heard of it. Is anybody using it? No one's heard of it? Okay, one. Okay, great. Okay, so this is an algorithm that was published in November 2012, so 2 years ago, and it was developed by an epidemiologist, Dr. Julia Hippisley-Cox, who basically looked at hundreds and thousands of patient records and looked at them retrospectively, and looked at records to find out what the initial signs and symptoms were well before the patients were diagnosed with cancer. It covers a broad range of cancers, including pancreatic, ovarian, colorectal, breast, lower GI, lung, renal, and is now introducing blood cancers and testicular cancers as well. A pilot has been conducted across the country, which where this program has been integrated into the healthcare record to allow GPs to use this checklist or symptom checker to see whether it would influence their decision making. And it's very similar to the QRisk that we use for cardiovascular disease. CR UK are currently evaluating this piece of work to actually show whether this does improve early detection of cancers. What the data is showing us at this stage, this very early stage of the studies, is that it is definitely positively influencing GP investigation behaviours and appropriate referral behaviours as well. So perhaps something else to take away with you today is to maybe go to the website, have a play around, perhaps take 3 or 4 of your last new cancer patients, input their data and see whether they actually come up as having a high risk, and whether had perhaps we used this calculator earlier on in the patient journey, they could have had an early referral or had investigations requested sooner. The checklist includes family history, other long-term conditions, symptoms and investigations requested in primary care in the last year. QCancer are working with EMIS Web to actually integrate all the software so that hopefully it's going to become automated and you won't have to be clicking and inputting data yourself. It's going to extrapolate all the data from your own record to populate the algorithm to be able to stratify your own patients and say which of your patients are high risk, so red, moderate risk, amber, and low risk, green. So with better read coding in our documentation, this algorithm actually might help us to detect cancer sooner. It's been nearly 10 years, I think, since the suspected cancer guidelines were published from NICE, and they are currently undergoing revision. The draft has been published, and I had a look at it on Tuesday. With respect to pancreatic cancer, or with respect to upper GIs, GI cancers as well, the thresholds have been lowered for investigations and referrals, and they have focused a lot on the sort of vague abdominal symptoms, the change in bowel habits, things that were more traditionally associated with colorectal cancers are now also being looked at for pancreatic cancers as well. And we mustn't forget that it's not just pancreatic cancer that can present in a vague way early on. We've got lymphomas, other upper GI cancers, and even renal cancers. So unfortunately, we couldn't play more of the patient videos, but I do urge you to go back and have a look and see if you can draw anything from the patient stories. Things that I hope you take away with you today are that there is new guidance coming out. Hopefully 2-week wait referral forms will be augmented to reflect that actually over a third of patients do present young, under the age of 65. Abdominal ultrasound scans can be falsely reassuring. What we need is urgent direct access to CTs. Safety netting and ensuring timely follow-up with our patients is important to minimise the number of appointments that it takes to get them into the right system. Trying algorithms such as QCancer and also listening to patient stories via healthtalk.org. And just before I finish, I thought that it would be important to look at different methodologies that we can use to improve our own cancer detection and conversion rates. So I don't know if any of you have access to your own cancer profile. Have any of you heard of practice profiles? Okay, this is a publicly available free resource that's housed on the website, the National Cancer Intelligence Network, and it basically has 4 years worth of data for your practices. It tells you your patient epidemiology, your accrued cancer incidence rate, the number of patients on your cancer care register, the number of 2-week wait referrals you've generated in the last year. It breaks it down into the top 4, so skin, bowel, breast and lung. It also tells you the number of patients that presented as an emergency and gives you also some figures on the number of investigations that you've used, specifically endoscopies that you've used from primary care. It tells you the percentage of your referrals that convert to a cancer, and that's called a conversion rate. And it tells you the percentage of cancers that you detected that year that came in via the 2-week wait, and that is called your detection rate. And a piece of work that we have been doing across London and other parts of the country is encouraging practices to look at their profiles every year and reflect and examine their numbers and see what changes they can make to improve their detection and conversion rates. I think, as I said before, 50% of pancreatic cancers come in via A&E, 11% of pancreatic cancers come in via the 2-week wait, which is actually a very, very small number. So that's one sort of method of how we can be better overall in our cancer services in primary care. Another project that I wish to highlight is the significant event analysis report and project that has been sponsored by the Royal College. All these templates are available on the Royal College website, and it's encouraging you to deconstruct patient journeys, especially those that present as an emergency or those that have an unexpected diagnosis. And through deconstructing the journey, you can actually tease out avoidable delays and then create action points, not only as an individual clinician, but also as a primary healthcare team to avoid future delays. Have any of you seen the Routes to Diagnosis spreadsheet? This is another piece of work that has been, I think it's been going on since 2009. And again, a fantastic service improvement exercise. If you've got trainees, this is something that they can get into. It's basically logging all your new cancer cases and deconstructing their journey. So looking at their age, gender, barriers to engagement, for example, mental health problems, housebound patients, if they're deaf, other long-term conditions that they may be suffering from that could be risk factors for cancers, how many appointments it took for them to be diagnosed, what the timeline was for their first presenting symptom to diagnosis, and what route of referral. Was it 2-week wait, was it routine, was it emergency, was it the private sector? And then what it does is it automatically calculates your total new cancers for each year, and it's just a valuable exercise if you're trying to tease out areas that we could be better in terms of early detection. So I hope those last 3 service improvement exercises encourage you to go and have a look. It's all free and it's all publicly available, so please do have a look. There has been lots of press about the cancer profiles, so it might be worthwhile you just having a look at your 2013 data to see if there's anything that you think you wish to discuss with your colleagues. And also with the evolution of QCancer, we're hoping that we can actually risk stratify our entire patient load, not just assessing patients as they're coming in the door and triaging them, but actually looking at our patients and saying actually which ones are high risk and being more proactive and preempting those that may qualify for having further risk assessment investigations. So I think that's the signs of future, the signs of what's coming along in the future. And just to reiterate, the 45-minute course on the Royal College website, which actually guides you through different patient stories, and it's not didactic, it's very reflective. It asks you to input what you would do next and why, and then gives some quite constructive feedback. So sorry if that's been quite rushed, there's a lot to cover. And if you can, please do visit the Health Talk .org website. And just to finish off, my last slide, this is a testimonial from a patient who had pancreatic cancer, who wanted to highlight how well the system had worked for him. He said, in his own words, "This shows that the system, when it works very well indeed. The NHS is the jewel in our country. What sophisticated society does not look after its people who are unfortunately laid low with a serious illness as I was. If I lived in America, I would have been required to pay for the operation or die. That is not a choice any civilized country should lay before the sick or ill. Please leave our NHS alone. It works. I'm living proof." Thank you.
Thank you very much.